Hello, my name is Dr. Tony Brown, and I will be your narrator for this session. The title of the session is Chronic Pain in the Hispanic and Latino Community. Estoy en el Gran Dolor. I am in great pain. This presentation will satisfy the education need by creating a program for pharmacists, pharmacy technicians, and nurses that will enhance their understanding of chronic pain identity, the differences in the pain experience in the Hispanic population, pharmacotherapy, counseling points, and information needed to work with all the patients to reduce pain and improve the quality of their lives. Potential communication issues span a wide range of concerns, including translation and literacy issues. So today we're going to talk about preparedness to address beliefs about pain, lifestyle recommendations that recommend cultural specific habits, sensitivity to common views about authority figures that may hinder dialogue. Now, the US Census Bureau estimates that the Hispanic population in the United States is greater than 50 million, or 15% of the entire population, and growing much faster than the national rate of 8%. Now, while many Hispanics speak English as their primary language, we have all had patients with whom communication is difficult. We hope that by better understanding cultural differences and biases, that pharmacists can, 1, help bridge this gap, 2, develop culturally relevant strategies, and 3, minimize disparities in the treatment of patients for not only their Hispanic and Latino patients, but for all patients. So what are our educational objectives for this session? Well, 3 things. 1, we're going to describe the difference in the pain experiences and barriers to care facing Latino and Hispanic communities. 2nd, we will review pharmacologic approaches to the management of chronic pain, pharmacologic profiles, efficacy, side effects, and adverse events. And 3rd, we will outline effective guideline-based, culturally relevant counseling techniques that pharmacists can use with Latino and Hispanic patients and caregivers in their daily practice to minimize disparities in treatment and maximize the quality of life for all patients. So let's start out by talking about exactly who is Hispanic or Latino. The ethnic terms Latino or Hispanic refer to a diverse population of Latin American descent that includes many nationalities and races. Latino refers to a person of Cuban, Mexican, Puerto Rican, South or Central American, or even other Spanish culture or origin from all around the world, regardless of race. Now, there is a consequence of this cultural diversity, and that is that there's a marked disparity in the quality of care that Latino patients receive. In a 2002 report from the Institute of Medicine, there were more than 175 studies that were cited to document this disparity. Quite a few interesting facts were discovered in this study. First of all, Latinos comprised nearly 16% of the U.S. population by 2009, making them the largest minority group. The largest minority group. Until that time, the order had been Caucasian, Blacks, and Latinos, and as of 2009, the 2nd and 3rd places were flipped. The estimation is that by 2050, it is projected that Latinos will comprise up to 30% of the United States population. Now, if we break that down as far as what the 30% may look like, the three largest subgroups would include Mexican Americans, about 65%. And Mexican Americans are mostly settled in the southwest region of the United States. The next largest group would be Puerto Ricans, comprises about 9.1%. They would be settled in the urban Northeast. And then the final group being Cuban Americans, who would make up about 3% of this number and mostly residing in Florida. Now let's move on to talking about various roles that contribute to this disparity in pain treatment for Latinos and Hispanics. The first role that we'll talk about in this session will be gender roles. So because of traditional gender roles emphasizing machismo, Hispanic men rarely complain about their pain. So let's talk about machismo for a moment. Machismo is a Hispanic cultural feature, and it's well known in the current literature. The literature studying gender roles for men and women, what it pointed out was that Hispanic culture instructs that men should be strong and in control and help meet the needs of the family, and women should be submissive, not having power or influence in the family. Subsequently, men are willing to endure a great deal of pain in order to show that they are macho males that do not show weakness by stating that they are in need of more pain medication. So it turns out that gender roles not only affect men, but they affect women as far as traditional roles and sacrifices that are made in Hispanic culture. The gender role that affects women is one called abnegada. Abnegada. In this particular culture, women who sacrifice themselves for their family are convinced that they need to shoulder all the burdens from household tasks and child rearing despite their disease. They tend to place their own needs, including their needs for pain management, behind other family members' needs. With abnegada, the decisions on pain management are made by the husbands or maybe by the fathers of the female patients. One female patient that I interviewed mentioned that her husband blamed her for being lazy due to her disease and pain. Now, a Hispanic woman may not report pain until it becomes very serious and intolerable in the interest of not wanting her family to worry about her. So, of course, you can see the problem here, right? Abnegada may begin with a pain that is absolutely manageable. It may be a disease process that, if caught early, it is able to be treated successfully. But because of this abnegada cultural specificity, a pain may be allowed to progress for weeks, months, years on end, right? And by the time the woman makes it to the physician to be able to obtain treatment, it may be too late for whatever process was going on to be reversed. Other things that may happen is that maybe she will go into the physician a little bit earlier in the process, but her healthcare provider may, one, think that the woman does not need pain medication because she's not complaining about it, or make other decisions based on current standardized practice guidelines that exclude the considerations of cultural factors. And that's what we're trying to help correct today, right? This insensitivity towards cultural factors in healthcare practitioners. If we spend a little bit of time studying what happens in other cultures, then we are able to be a little more sensitive and maybe pull out some of the answers that we're looking for, maybe ask a few leading questions going towards where we think might be something that's happening. But as long as we have a little bit more knowledge, maybe we could be a little bit more effective. Now, gender roles are not the only roles. Let's talk for a moment about the role that family plays in this entire situation. So patients place the highest priority on family during the diagnosis and treatment process. And so thus, with Hispanic patients, they tend to set aside their needs for pain management. The cultural tradition of responsibility towards family at the expense of one's own needs tend to make it so that, for instance, Mexican patients with serious illnesses are less likely to be told, this is at the request of their family, they're less likely to be told that their condition is terminal. Latinos tend to have a similar family-centered model of decision-making, and we're also more likely to withhold a terminal diagnosis from the patient family member. The explanation here was that families did not want to harm the patients with their knowledge of their short life expectancy. Families believed that it was even more merciful to withhold painful information from that patient rather than tell them, with the idea that since the patient may have had a short life expectancy anyway, it was the responsibility, it was the duty of the family to make that patient as comfortable as possible, to maximize their quality of life in the short time they may have had left. And maximizing the quality of life meant not stressing them out with the knowledge of their imminent death. Still talking about the family role, Caucasian patients with serious illnesses tended to place the highest priority on their own individual experiences and interests, and wanted to have control of their bodies and their lives. And that's what we're used to, right? We're typically used to, in a typical tradition of going in to see our physicians and our pharmacists and nurses, we're used to being pretty autonomous about our medical care decisions, not necessarily handing it over to the males in the family. Maybe we would get input, advice, but not necessarily advice and consent all of the time, right? So this is one major difference. Hispanic patients tended to emphasize the welfare of family over individual care. Consequently, Hispanic patients with diseases such as cancer were more likely to seek support from family members, friends, and healthcare professionals. A patient from Puerto Rico who had been living in the United States alone for over 30 years discussed his loneliness, saying, "I'm sitting here by myself, and just like everyone else, I need the company of somebody, and to have the family, I need my family too." Another interviewed patient stated, quote, "The only people that I count on to help me out are my family. I get support from my husband and the children. I call my children when I am in severe pain. Since I have my family, I really don't need a support group, since my family is the support group." Right? So you can see the problematic nature of this particular cultural entity, that considering your family your first line of support, that's not an issue. Considering your family your only line of support may be problematic, because it would prevent the Hispanic or the Latino patient from seeking out support groups, right? From seeking out first and maybe second or third opinions from their healthcare workers. And at this point, being a lot more dependent upon maybe the experience of another family care member who may have had that same illness or had that same problem or happens to already be taking the same medication, right? So you get a lot of non-professional advice as a result of not seeking the healthcare professional advice. Let's talk about the role of identity. Patients endure inconvenience and unfair treatment in the U.S. healthcare system while simultaneously appreciating what treatment they are receiving. This is a terrible place to be in, right? You feel thankful for the service that you're getting, but somehow feel as a second-class citizen while receiving those services. It's just an awful place to be caught in between. One of the terms that we will discuss in this session is the term of undocumentedness, right? This is a factor of the identity role. Undocumentedness encompasses quite a few things. These are ways that Hispanic and Latino tend to feel in the presence of healthcare workers, physicians, those who are taking care of them. It is not necessarily true. And I want to make the distinction between a feeling that the patient may be having from prior experiences before they ever arrived to maybe your institution versus something that may actually be true. May be true, but it's not necessarily true. Either way, what is true is the pain, is the feelings of vulnerability and being out of control, is the fear. Those things are true. And those are the things that we're trying to approach today. So let's talk about this idea of undocumentedness. One of the feelings is a feeling of being exploited, right? One of the people that I interviewed mentioned that when they do have insurance, they sometimes feel like when they come into the physician's office that unnecessary tests are being ordered, perhaps unnecessary assays and lab results and these kinds of things. And it's very difficult if English is your second language to verify in just plain old street language English, right? It's very difficult to verify whether or not what's being ordered is necessary, let alone medicalese, right? These long medical words that we encounter on these forms. If you were given 5 or 6 tests to take after your doctor's appointment, and maybe in your mind you only believed you needed 1 or 2, there's really nothing you can do other than just take the tests, pay for the tests with your insurance, and hope that you're having a very honest relationship between you and your healthcare worker. This is the exploited nature. Undocumentedness also encounters being marginalized, right? This is the feeling of walking into the office and maybe, though you're third in line, you get called fifth, right? Or maybe you're waiting on the side while other English-speaking patients are being taken care of, while the non-English-speaking patient waits to the side until perhaps another Spanish-speaking coworker arrives, or maybe the service personnel has a long line and they want to get through all of the English-speaking patients before taking time with the non-English-speaking patient for fear that it's going to take an extra amount of time to take care of. Also, with undocumentedness, you have this feeling of uninsuredness, right? To be uninsured, whether or not you are, Hispanic patients feel that most healthcare workers look at them as being uninsured, as being a drain on the system. as being lazy, can't go to get a job because of whatever reasons, but in not having a job, they don't have insurance, and in not having insurance, to drive up the insurance costs for everyone else. Yeah, so it's really a feeling of being blamed for the status of insurance in our system, and perhaps actually having nothing to do with it. Undocumentedness also includes being discriminated against in subtle ways like those we've just talked about with marginalization, and maybe sometimes in not so subtle ways. Right? We've seen this before, how a person who is non-English speaking may be ridiculed or made fun of, or simply even ignored, just absolutely ignored, because a person may not want to take the time to try to speak another language other than English. Undocumentedness also encounters feeling illegal, whether or not you are. Right? To be viewed, to feel that as you're walking down the street, that others are viewing you as illegal. Do you have the right to even be in this country? This kind of thing. Undocumentedness encounters feeling blamed. Blamed for what? We just talked about it. It could be blamed for high healthcare insurance costs, or being blamed for low wages, or a partridge in a pear tree. To be blamed for just about anything a person can blame someone for. Undocumentedness means feeling vulnerable. You're walking around in a place where, the street signs, the instructions for your doctor, the instructions from your pharmacist, the inserts in your medicine, all of this is in English, and some of it is very, very subtle, right, as far as dosages and frequencies. And you're afraid that you might miss just one turn of a word, one misinterpretation of a phrase might end up with a problematic adverse effect for your medication. Undocumentedness is a feeling of out of control because of everything we've just talked about, right? Lacking this feeling of really controlling your own destiny from a day-to-day standpoint. And then finally, undocumentedness means feeling like you're a prisoner in the very system that's set up to take care of you, right? This system where you're supposed to come to in a time of need and unhealthiness and sickness, but feeling like a prisoner in that very same system. So another patient that I interviewed, Ms. Garcia, mentioned, quote, "People assume that I am Puerto Rican and treat me as such. I was born in New York City, grew up in Sleepy Hollow my first 7 or 8 years, and then went to Cuba. My stepdad was Cuban, and my mom is of Spanish Syrian ethnicity, but did not speak the language because she was born and raised in Philadelphia. My dad was Spanish and Dutch Jewish. From Cuba, where I was called La Yankee, we migrated to the Caribbean, and when Mom decided she did not like it here, they left, but I stayed. What I perceive is the notion among Americans that Latinos are lazy, histrionic, and drug seekers, seeking drugs via complaining of pain, and in general treat us with disrespect. Even when people know I am a physician and a bioethicist, I am treated differently than the Americans in any group, including by other physicians." Okay, so let's talk about the role that religion plays in this. Ill patients tend to perceive illness as their destiny. Now let's think about that. If you were to perceive illness as your destiny, that is to say, if you believed that this illness was cast upon you by the God that you believe in, then somehow in the back of your mind, you're thinking, then I should just endure this. I should just overcome. I should just deal with it. Because somewhere in the back of your mind, if you think it is the will of your God, then you do not want to go against the will of your God. And you are a lot more likely, as in this tradition, to just simply deal with it. Line 2 here, it invokes a sense of powerlessness and helplessness. Line 3, thus, Hispanic patients approach pain with stoicism, a kind of, don't complain about it, don't whine about it, don't talk about it, just kind of hunker down and wait until it passes. There's a lack of verbal and behavioral expression of pain, and to remember that does not indicate a lack of pain itself. And as we just mentioned, the religious roles would certainly affect compliance, right? This means that the patient may be more likely to pray about being healed than to take the medicine to heal them. And this means that they may not take the medicine at all. Maybe they would begin taking the medicine, and if they don't see a difference in the first day or so, to think that it's worthless and stop taking it. So this is absolutely a point where pharmacists and pharm techs and nurses can come in, because it's you guys that can explain to them that, for instance, antibiotics. If you're going to take antibiotics, take the whole bottle. Don't stop when you feel better. Or if they're taking antipsychotic medicine, to explain to them that it may take up to 6 weeks for therapeutic concentration to be achieved. Don't stop before that time, because the full power, the full efficacy of the medicine hasn't been realized. Because it's in these times that they are very likely to just put the bottle on the top and do away with the medicine, putting it up until the next family member gets sick. Okay, let's move from religion and talk about the role of the prescriber in all of this. So when we talk about the prescriber, we're talking about whoever it is that's writing the prescription. And the issue here tends to be one of undertreatment, right? So one study cited that Hispanic veterans with osteoarthritis received fewer days' supply of a nonsteroidal anti-inflammatory drug than the white veterans did. Another study showed that Hispanic children received 30% less opioid analgesia after a tonsillectomy or an adenoidectomy than white children did. Let's talk about the role of workforce. This is a matter of underrepresentation. So during the years 2001 through 2007, Asian and white PharmD students accounted for 90% of the total enrollment in California's 7 programs. Now, understand that California's enrollment statistics are comparable to the national PharmD enrollment statistics. The American Association of Colleges of Pharmacy statistics shows a slight upward trend in the number of Latino students that enrolled in California's programs over that same period of 2001 to 2007. But unfortunately, this was mainly because of 3 new programs that had opened during that time. And it was not an increase in their proportional representation, more just a blip on the radar, if you will. More enrolled at that particular time. And then after the enrollment for those 3 new programs stabilized, the numbers and the statistics returned to the pre-2001 levels. Collectively, underrepresented students, this is not just Hispanic, but collectively, underrepresented students continue to represent only about 8% of the PharmD student body in California. Now, there are some gender specifics in this workforce underrepresentation. During that same period of 2001 through 2007, women consistently represented about 70% of the total enrollment. Asian women, roughly about 45 to 50% of the total enrollment in those PharmD programs. And the proportion of Asian women enrolled in California's programs is roughly 3 times the size of Asian women enrolled in PharmD programs nationally. So let's talk about the role of socioeconomics here. Sometimes, based on the place you live, based on your zip code, you have fewer resources and greater difficulty in accessing care and filling analgesic prescriptions, especially for patients of low socioeconomic status. We've heard of this, right? With regard to food and groceries, there are places in some inner cities called food islands where you could go out and walk for miles around and not run into a grocer, a full service grocer that sells fresh fruits and vegetables and healthy food. This is different from the corner store that you see popping up everywhere. But these are called food islands. Likewise, there are pharmacy islands. And pharmacy islands, there are these areas in a neighborhood where one either needs to have a car or needs to access mass transportation, which is probably not accessible in the neighborhood, in order to make it to a decent pharmacy, which is going to, 1, even have their medication in stock, or 2, be able to refill it. So, yeah, this is the role of the socioeconomics. Let's move on to talking about the role that language plays. Now, as you might expect, the most common reason cited for non-compliance with pharmacologic treatment was inability to understand instructions. So it turns out that difficulty in understanding the language, this difficulty for healthcare providers was a major factor because it really prevented them from adequately assessing the pain in their patients. And you can imagine what that looks like, right? The patient is in the practitioner's office, and the practitioner may be doing a lot of sign language and pointing and maybe touching, but not really getting to the nitty-gritty of where the pain is. Does it radiate? How long have you had it? These kinds of very subtle questions. Was it there when you woke up in the morning? Did it, these kinds of subtle questions assume maybe not a mastery of the language, but certainly a bit of proficiency in it. Let's move on to this feeling of Hispanic patients feeling like a prisoner in the healthcare system. So here's another interview. Quote, "I noticed that there was a Caucasian lady ahead of me while waiting in line. The clerk treated her very well. She asked her how she was doing. But when it was my turn, she was very short and curt with me, and she treated me very differently. The clerk did not treat me the same as the other people, and this made me feel very uncomfortable, but I cannot do anything about this situation." Okay, let's move on to the demographic role. Latinos suffer from certain illnesses at higher rates than non-Hispanic white Americans. For instance, approximately 31.9% of all Latinos were obese in 2010, compared to 26.1% of all whites. Now, this disparity was greater among women, with 33.1% of Latinas obese compared to 24.5% of white women. Latinos are less likely to have heart disease compared to non-Hispanic whites. Now, this is primarily due to their young median age. When you take account of the nearly 50 million Latinos in the United States, the median age tends to be somewhat younger than both African American and whites. That's the good part of that statistic. The not so good part of that statistic is that Latinos face higher rates of risk factors that can lead to heart disease. Like what? Like what we just talked about on the previous screen, obesity and diabetes. So what we're saying here, lower rate of heart disease, however, higher rate of risk for heart disease, which in time begins to turn into a higher rate of heart disease. Another example is that Latina women have disproportionate rates of cervical cancer, which they contract at 1.6 times the rate of white women. Only 46.5% of Latinos received a colorectal cancer screening in 2010, compared to 59.9% of non-Hispanics. More demographic role, Latinos are one of America's most disproportionately uninsured populations. As many as 1 in 4 uninsured individuals who are eligible for coverage through the health insurance marketplace nationwide are Latino. Now let's talk about the progress that we've had in this area. Investments in data collection and research will help us better understand the causes of healthcare disparities and develop effective programs to eliminate them. This was a statistic that was put out by the U.S. Department of Health and Human Services. Major federal investments to improve quality of care are improving management of chronic diseases that are more prevalent among Latinos. The healthcare workforce is more diverse due to a more than doubling of the National Health Service Corps. Latino physicians make up about 10% of this corps, a percentage that greatly exceeds their 5% share of the national physician workforce. Increased funding that is available from the federal government is going to more than 1,100 community health care centers, which will increase the number of patients that they are able to serve. At the present time, 1 out of every 3 patients at a healthcare center is Latino. Now let's talk about the cost of education. And this progress has to do with the workforce imbalance that we spoke about a few moments ago. So, as of August 2008, 4 of the 7 schools of pharmacy in California were private schools. As we all know, these private schools generally have higher tuition rates compared with the public universities. So one thing that could happen is that the private pharmacy schools could continue to remain competitive while offering financial incentives to students from economically disadvantaged backgrounds. Presently, there are other efforts going on, right? One major problem is that there are low levels of awareness of pharmacy as a profession among students. Students who are in disadvantaged background, they may be considering health professions, but not aware of pharmacy as a viable profession. So, increasing awareness was addressed by a new initiative at the School of Pharmacy in the University of Southern California. USC undertook this effort to increase student diversity in the School of Pharmacy by pairing underprivileged high school students with PharmD student graduates to give those high school students a better sense of the profession. The idea here was that the program was to employ this multi-tiered approach focused on raising awareness throughout not just high school, but the entire education pipeline about what a wonderful career you guys are in, this career of pharmacy. The main component of the initiative involves mentoring and pairing students. So let's talk about what you can do. The most important thing you can do, you're doing right now. You are involved in continuing education. Okay? So I just want to encourage you guys to keep doing what you're doing and keep seeking out very interesting topics, because It's in this seeking that you're going to be able to find different threads that connect to this particular subject, educating yourselves not just on, the cold, hard facts and medicine of pharmacy, but on the culture of it, on the things that we're talking about today. Something that may be forthcoming in the literature, this idea of pharmacogenetics, right? We've been talking about this for a while now. So with pharmacogenetics, the idea of having personalized medicine, distinguishing whether or not a patient is a fast metabolizer of a drug or a slow metabolizer. You all remember this, right? Fast metabolizers may have to have increased dosage and frequency. Slow metabolizers, maybe not so much. There has been research in this area. Unfortunately, not a lot of research in Hispanic and Latino genetics. For instance, pharmacokinetic studies of codeine. They have determined that up to 10% of certain ethnicities obtain no pain relief from codeine, which would be due to the lack of an enzyme which is needed to metabolize codeine to morphine. But again, I said certain ethnicities. Neither of these certain ethnicities is Hispanic or Latino. So you can imagine how this role of pharmacogenetics might play into the undertreatment that we've talked about in this session of Hispanic and Latino patients. A recently published position paper authored by the members of the American College of Clinical Pharmacy envisions a future pharmacist workforce assuming greater responsibility and accountability for managing drug therapy in direct patient care settings. Right? So what's that saying? It's saying you guys are the hottest thing on the street right now. That not only will your responsibility increase, that the demand for workers like you will increase, your notoriety, your popularity, your respect, all of this is on upswing. Pharmacy is moving to the front of the stage. So over the course of the next decade, providing direct care for patients in all patient care settings will become standard practice for virtually all pharmacists. Again, you guys are taking over. You're the hottest thing on the street. The future role of the pharmacist as an integral member of a patient's team of primary caregivers raises important issues regarding the level of cultural competence practiced by pharmacists. There is a need for multilingual and multicultural pharmacists to communicate complex drug information as well as address cultural beliefs and practices about the use of pharmaceuticals. So let's talk more about what you can do. Another thing would be to recognize normative values in the Hispanic culture. What do we mean? Well, there is one value referred to as simpatia. That's kindness. This value emphasizes politeness and conflict avoidance. And to understand this value means that when you're having a conversation with a Hispanic patient, maybe the Hispanic patient, it raises a question of concern or doubt, and then you respond to that. If there is not a second pushback, right, a second comment, it does not necessarily mean that they agree with you. It may simply be an expression of the simpatia, of not wanting to have public episodes of conflict. Personalismo, right? Friendliness, a personal connection that can be achieved by asking about the patient or his or her family. Now, because people tend to stand closer to each other in most Latino cultures, this means that physical proximity is also perceived as being more personable. So I'm not saying come down from around your counter. I am saying maybe lean in while you're talking to your patient. If there is no counter between you, stand a little closer. Make it more of a relationship and less of a transaction, right? Let's talk about the normative value of respeto, respect. Respeto implies an attentive concern for the patient and respect for his or her personhood and age, especially if the patient is older. Older patients prefer to be addressed as señor or señora rather than by their first names. Using don or doña with the given or full name indicates an even greater respect for older patients. Recognizing normative values when addressing patients, for instance, using the correct form of their names. So we've all had problems with this phenomena of double or hyphenated Latino surnames, right? The father's name, if you have a single woman, the father's name precedes the mother's name. So a single woman may be named Sofia Gonzalez Rodriguez, Gonzalez being the father, Rodriguez being the mother. And then she gets married to a man named Marrero, whose last name is Marrero. When this happened, her husband's name may be added to her father's name. So instead of being Sofia Gonzalez Rodriguez, she is Sofia Gonzalez Marrero. Now, as it happens, after immigration, some Latinos adopt American naming conventions, but others don't. So I know this can be confusing. Therefore, when in doubt, just ask. Proficiency is something else you can do. So proficiency is actually required under Title VI of the 1964 Civil Rights Act. Whenever possible, try not to use patients' family or friends as your first choice for interpreters. Also, you can be an equal and balancing force, right? Because clinicians tend to over-rely on pain scales in clinical assessments instead of just exploring the pain in every multifaceted way and including its characteristics and its symptoms. Okay, you can be a help because you're the one that's going to be face to face with the patient. You can, for instance, compare how often you see them refilling a prescription to how much pain they seem to walk into the door with. This might be a sign of undertreatment. Okay, going back to what you can do. Cross-cultural complaint handling. Handle the complaints sympathetically. Listen to the patient's perception of the problem. Explain your perception of the problem to the patient, and then acknowledge and discuss any differences and similarities between the two views. Then you can just recommend and negotiate an agreement. Okay, so final 3 slides here. Pharmacists, we're talking about working with medical interpreters. Pharmacists should understand and glean skills in effectively working with interpreters. 1990's American and Disabilities Act provides for interpreter services, including sign language interpreters. So pharmacists want to understand the process for obtaining those interpreters and realize that when you do use family or friends, you're getting secondhand information, and some of that information might be corrupted. So if you want to work in a culturally competent pharmacy, right, treat all patients as people first. Assume that all interactions with patients are cross-cultural, even though they may not be cross-racial or cross-ethnic. Engage the patients in your learning about how culture should be considered in the context of their treatment. Know your own attitudes and your own prejudices, right? We all have them. And keep in mind that there are no substitutes for good attitudes, knowledge, skill, empathy, caring, and a sense of humor. These are your resources. My gift to you.